here on the panel. Bettina Durovny from Fiocruz in Brazil. Bettina was previously working with the Rio government as an undersecretary and as a consultant for the Rio's Brazil's national TB program. Fumiza, our patient advocate from TB Proof, and Beatrice, the NTP manager from Tanzania. I would also like to invite Dina Nair. She will step in kindly for the National TB Program Manager from India, who could not join us today. Dina is with the National Institute of Research in Tuberculosis, also called TRC in Chennai. Can you all check if the mics are working, please? All right, thank you. So can I start with you, Fumiza, as our patient representative? I've met you in South Africa. I know a little bit of your story. And when I show you these patient pathways analysis or care cascade analysis, the long diagnostic delays, the number of different providers that people have to see before they are diagnosed to have TB, does that resonate with your experience? Was it a straightforward case in your case where you just walked in and you were diagnosed, or did you have to navigate a very complicated process?
So at the time, the expert machine wasn't available in SA. So then I had to cough up the sputum and wait for 3 weeks to get the results. And at the time, I was sick. I couldn't walk. So by the time the results came back, they didn't show any signs of TB. So my TB was only seen on the X-ray that they suggested I must do.
And so how many different health systems did you have to navigate? I mean, in your community where you were living, when people fell sick, where would they normally go to? Did you do something similar, or did you think you already have TB and you did seek specialized care?
So because I was a student, so that meant I didn't have much time. So I went to a private doctor because there are no lines in the private sector. So I went to the private doctor. The doctor checked me all for the common diseases. They all came back negative. Then the doctor said I must go to the clinic, and by the time I went to the clinic, I think it was too late. And even if I went at the clinic, they checked me out, they didn't see TB, so I don't know what was wrong. They didn't know what was wrong.
So South Africa has a private sector as well, and yes, we know while it's not in the same magnitude as India or Pakistan or Bangladesh or Indonesia, it is still a sizable sector. Do people in the South African communities also seek care with traditional health healers? Sangomas, other healers in the community? Is that a common practice?
Well, yes, and that's a big problem because the Sangomas, they throw bones and then they see your future, apparently. And then they give you medication, and then some will advise you not to go to the white doctors. And then by the time you drink your medication and it doesn't work, it won't work, obviously, and then people die, and then they spread the disease, and then it becomes a problem. That is already a problem there now.
And so from what I read in the South African health-seeking literature, there are provinces where traditional health practitioners are almost always the first point of care. And if they don't have the ability to diagnose TB, which we know they don't, no matter what bone test they may use, it's not possible for them to diagnose TB. That means almost always some degree of diagnostic delay is guaranteed in the system. And I think when the time they even come to the NTPs, a lot of time has already passed, and we know that's a genuine issue. In India, for example, millions of patients go directly to pharmacists. That is where they think they can get rapid relief for their symptoms. They do not want to waste money on doctors and consultation. Go straight to a pharmacist and say, I have cough, give me something. And we've done mystery patient studies which suggest that if you walk into a pharmacist in India with classic textbook description of TB, and we know because we made those patient actors pretend to have TB symptoms, they spent 1 minute with them, asked one question, and charged $1. And they practically all gave broad-spectrum antibiotics, including quinolones, but not one of them gave away anti-TB drugs. Thank God. That's the only positive thing that came out of the study, that pharmacists were not handing out rifampicin like candies, but they were giving out quinolones, amoxicillin, and a whole slew of other drugs. But what was sad about that study is that although they could have easily said, in addition to giving you whatever I'm giving, can you go and get tested at the nearest DOT center? That referral was practically non-existent. The pharmacist did not even bother to say, go get tested for TB, hardly bothered to ask even a few questions. How long have you been coughing? Are you producing sputum? Do you have fever? Maybe 3-5 seconds of questions, and then a referral slip to some nearby DOTS center for a free test. Let them give out whatever they're giving. But in addition, can they at least be a source of improving our case detection, which I think is really worth for countries like India to exploit. Beatrice, in the Tanzanian situation, tell us a little bit about what your understanding of patient care-seeking pathways are and how you intend to address that in your country.
Well, that's a tough question. So, Madhu, for me, I think, in my opinion, there is still a significant level of, of apprehension, of being too restrictive and conservative and too careful when it comes to TB diagnostics, to TB treatment. If I give an example of the widespread, the widely used microscopy tool we've been using, for instance, in my country for a while, I think we know the recommendation that was, back in the days provided by WHO, and not to blame WHO because, having guidelines and standards is good, otherwise it's going to be chaos. And the recommendation for countries to follow as a standard for having that threshold of microscopy centers that are sufficient for a specific coverage. And I think it was one microscopy center per 100,000 population was considered sufficient for a long time. And countries do follow these guidelines for, by and large, because, they're informed by experts, and a lot of thoughts has gone into those. And, for a country like Tanzania with 40 million, 50 million people, the implication is that having 400, 500 microscopy centers was sufficient, was more than enough, and we had 900, 800, some of them at one point in time, 100, a few hundred were not working, but still, as a program, you would be pretty confident that you're good. If you're having 800 microscopes, that's double the amount that is recommended, right? Mm-hmm, mm-hmm. To a point where you even ignore the private sector. I mean, what significant value can the private sector add if I have all these microscopy centers that are well coordinated, and they are, we have enrolled them in EQA programs, we are training the laboratory staff, etc. But when you go to the reality, to the ground, you realize that that same country has 3,000, 4,000 health facilities with some, element of diagnostic services, which provide microscopy services for other issues, for other diseases.
But not for TB.
Not for TB. Yes. They would test for urine, for stool, for malaria back in the days when there was no MRDT. And 400 out of 3,000, 4,000, 5,000 diagnostic facilities, leave alone the private facility. You do the math. That means patients have to walk. They have to work towards getting a diagnosis for TB. Yes. Now, for good reasons, these are microscopy centers that are well controlled, etc. But then we more often than not, we are compromising issues of access, because of that. Because of that. Now, like I said, I don't want to blame WHO. WHO is an organ. We are WHO because we go to those meetings, and we provide our inputs as country experts. We provide our country perspectives. We provide our expert opinion to inform the recommendations. And I think the key issues should be to recommend appropriately having, patients' access in mind, and then think of issues around quality.
So I was thrilled to see your quality improvement manual that you sent me.
Yes.
So let me just emphasize for the audience an important point that you're making. You're saying in your country you have many more primary health facilities than the ones with an attached microscopy center.
Exactly,
right?
exactly.
And so even microscopy has not penetrated the public primary healthcare infrastructure. Same thing in India. So, Dina, India has 26,000 PHCs, somewhere around that, and we have 13,000 microscopy centers. So even in India, only half of all PHCs are outfitted with an attached microscopy center, which means if you do not, by luck, end up in a PHC with a microscopy center, even smears are not guaranteed for you on that day. And then we said, come back on 2 days, 3 days to give multiple sputum smears. We've already see where patients are going to drop off in this health system, right? So even smears are not guaranteed in the public structure because not every primary health center, and let's not even talk about private, informal, because none of them have worthwhile microscopy also in those settings. So is one answer increasing the number of microscopes to saturate all primary health facilities, at least in the government?
Exactly, because look, we have now the prevalence surveys that tells us, we are missing these cases. And you know what we do? Because we are already restricted in our minds that, the microscopy centers should be few and we should have a good control of those, et cetera, et cetera. So we are thinking of other innovative ways. We are training layperson to fix sputum. Mm-hmm. We call them sputum fixers, and pay them to transport, to fix sputum in facilities where there's no diagnostic facility for TB, even if there's a diagnostic facility for other issues and there's a microscopy at the site, to transport the specimen to where there's a TB diagnostic facility.
So instead of making the patient run around to get a diagnosis, you will collect the sample and make sure it's sent.
A layperson who has been trained. But I think that the most reasonable solution would be to expand.
And microscopes are not expensive or difficult to
They're not
scale
difficult,
up.
exactly. And we have started to do that, and now we have about more than 1,300. But I mean, it's doable.
It's doable.
It's doable.
So let me ask you one more question, and then I'll come to Dina. If microscopy is not even saturating the primary health infrastructure, is there any hope to add a triage test first, and then only do all of this if the triage test is abnormal? Now, I'm talking about chest X-ray, because there is nothing else that the TB community has right now, as of today, that is a worthwhile triage test. But X-ray is a bankable triage test. It's a darn good screening test. If an X-ray is abnormal, that subgroup of patients, we can spend much more time with them, get the sample, maybe even a gene expert becomes viable because it's a much smaller population rather than everyone with suspected TB, because that is a problem for the NTP, that everyone with suspected TB is too large a group to do a gene expert on, because 9 out of 10 will be negative, right? So we know that that's one of the reasons why NTPs are not able to widen the net much, because we'll waste a lot of cartridges. So where is the X-ray in your Tanzanian public health system? And do you see X-ray as a viable triage test at all in your context?
Well, I do see it as a viable triage test, but again, issues of access, because it's not everywhere. It is. So
where is it in your health system?
Mainly from the district hospitals level, and not
which
in
is consistent with what I showed you. So
exactly.
This, I think, is a consistent thread, and the reason why it dampens our enthusiasm for X-ray is that while its characteristics are wonderful in many ways, it is just not available at a lower level in most countries. But if you switch to cities, urban areas, I'm sure the situation is much better for X-ray access. So there's still an massive urban TB community where we can leverage a chest X-ray. And if you go to an average Indian town or city, X-rays are dime a dozen. Really cheap, very widely available, comes with the radiologist report. You don't even need CAD or anything, right? It's all possible and doable. But at the public level and at the primary care level, I think even India doesn't have X-ray in most PHCs. Is that correct, Dina? So how do we overcome this big problem that we do have a triage test, but it is only accessible at a higher level? Dina, you want to try this question? What's the Indian programs thinking on chest X-rays right now? Can you take a mic, please?
Actually, even in Indian setting, even in the primary healthcare centers, we don't have the infrastructure where we can put the chest X-ray machine. So it's available only in the district level, like the TB units. So one way is, I don't know, but maybe a mobile chest X-ray to reach the periphery or something would help.
I mean,
Yeah.
we've used mobile X-rays primarily for prevalence surveys. I think it's challenging to do it on a routine basis. And unless the technology, the hardware costs dramatically come down, make them more deployable, you need consistent electricity to pull off an X-ray machine. Not to speak of trained reading, which is a whole other story, which is why some of us think that the CAD algorithm might take away the reader problem. You still need the hardware at that level and maintain. But the good thing about a chest X-ray is that it's not just for TB. You can use it to diagnose a fracture, a child's pneumonia. It's a genuine primary health strengthening tool, if you wish. And I think an X-ray should be considered an essential diagnostic test in any country's primary health system because it's cross-cutting. It's not a TB-only test. There's tremendous utility for it outside of TB as well. Do you want to respond to that, Louisa? You want to respond to that, Louisa? All right. So you were saying in the Indian system it's challenging, but in cities at least and towns,
cities it's possible.
It's possible, and there's already lots of diagnostic centers, and I think the program is already thinking of making X-rays available by purchasing services in the private sector.
Yeah.
Bettina, tell us about the Brazilian healthcare infrastructure and where you see. So you now have GeneXpert, right? But you are again using it only in selected groups, or are you broadly using it among all people with presumed TB?
So Brazil has a strong public health system. It's not perfect, but it's a strong public health system that covers around 60% of the population. It's 200 million people with family health doctors and community health agents. So the way the GeneXpert was introduced was to actually cover 60% of the TB cases, which are mostly concentrated in big cities. It's an urban disease. So we do, actually, the design was to replace spit and smear. And in the first phase, we tried to decentralize it. And we stepped back a little bit and we re-centralized it a little bit because it was easier to do the logistics of the sputum than to actually maintain the machines, the equipments close to the services because there were problems and capacity. And so we stepped back a little bit. We concentrate the equipments in the sub-district level and we do more the logistics of the
so
specimens.
if the patient walked in, and there is no GeneXpert in that center, do they have to go to the next level, or you will collect the sample?
All the tests are mainly collected at the primary center, and it goes to the lab, and the results come back.
Okay, and
so
how long does you think it'll all take for the patient?
In the big cities, it's not so long. The two things that we accomplished with the GeneXperts were actually time to treatment and more MDR
picked up.
Yeah, picked up. We didn't have a good yet results on cure or mortality, but these two operational indicators were really improved by GeneXpert. But still, I think that for big cities, this point of care thing can be calibrated in terms of the logistics that you can run. Maybe in more remote areas, we have to come up with more light point of care things that will prevent people to travel some distance. And Brazil has a lot of remote places, and especially for some vulnerable population like the Indians and other people around. But even with a health system that is designed to be very close to the communities, we still have people that are out of our radar, like people that are really poor, that still don't appear on the services. But in a more systematic way, all the things that they need are done there. And as you know, there are no TB drugs in the pharmacies, so they have to go to the public sector for treatment.
Correct. So if, assuming that more point of care or decentralizable molecular tests are available this year and after, which they will be. Omni, this is a small portable system. India has a product called MolBio, which is already being validated by NIRT at the microscopy center level. China has something called U-Star, which is producing something similar. Quantum DX has something similar. So there's a whole slew of portable, more decentralizable molecular TB tests that are coming away as of this year. How does a country like Brazil envision, you still have all of your GX4s that you purchased already. You're not going to throw them away. So you're still going to use them as you're doing them now in a fairly centralized manner. Do you still, you think there's a role for a dual approach? In some situations, you would use the point of care Omni. In other situations, you'll use the existing.
Yeah, I think this is the idea. I think that if the first studies that are being conducted with the Omni are in remote areas for special populations, and I think this will be complementary to what we already have
What
in
you
our...
already have.
Yeah, this is the idea.
And Dina, do you have any sense of the molecular tests in India? So in some sense, a locally made product is attractive for India, and the Indian government has explicitly made in India as a linchpin for the Prime Minister Modi's government. There's a lot of investments being happening. The India TB Research Corporation, R&D Corporation has been launched as of November, that Soumya has spearheaded. Tell us a little bit about how India is seeing local R&D, both diagnostics and drugs, and how it might one day come into the program. What's the thinking around local R&D in India?
I think we should validate the tools, the indigenous diagnostic tools, and then we should do feasibility test so that it can be, so that it's available as a point of care test at the primary health center.
Yeah.
It will be like a cheaper solution, and also it should be more sensitive so that the diagnostic delay is much less.
So that's the plan from
yeah.
what I've seen. I just got an email from Banu that MolBio and Omni are both going to be validated at the DMC level.
Yes.
And then you will wait and see whether these tests are better and can be feasible at the microscopy center level to pull it off. Beatrice, is there any room for more decentralized molecular testing than it is done today?
Yes, we I wanted to say, advocate for simpler, rapid molecular tests that can be put at the point of care test before, the previous speakers. So I think they read my mind. We have about, 70 machines now in country, and now that's very few. By any standards,
They're all centralized?
They're all centralized at the district levels, and that covers almost less than half of the district hospitals. So much as I think it is important to strengthen the health systems, but that's a tall order, for a TB program. It's a tall order for the Ministry of Health, and the ministries are now, our ministry is now realizing that strengthening the health system is very important and goes hand in hand with, eliminating these diseases. But that's not a one day, it will take time. Meanwhile, we are now expanding this gene expert to at least have a reasonable geographical coverage such that all the district hospital at least have a gene expert machine. But we're also thinking of, once the Omni is available, of, hand in hand, replacing, the current light LED with the Omni, which is simpler, cheaper, and can be used at those lower point of care.
So I hear you. You would like to take the newer molecular tests lower.
Yes.
But even your existing gene experts, are you happy with your utilization?
I'm not happy, and that's that's like an egg and chicken question, Madhu. Because if you have 60 machines, only 60 machines, in a healthcare system that is not very strong, not very efficient in terms of, specimen transport, and you don't have a good electronic R&R for feedback of results, etc. You cannot avoid but have, diagnostic delays and treatment delays for these patients who are diagnosed at centers where there's no a gene expert machine. That's one. Two, to begin with, that just like you said, the algorithm was restrictive when it was first recommended, and therefore there was an issue of acceptability of all those issues that came along with the test when it was introduced. And by the time when lab technicians had accepted the technology, already there was this issue around where do you place, how do you structure your algorithm such that it fully optimizes the technology. We did have a meeting to revise our algorithm with partners, FIND and in-country partners, and it was a very interesting experience where we came up with an algorithm that at the end looked like a spider's web. Where there's an expert machine, everybody should be tested. We opened up the
criteria.
To test everyone. Where there's no expert machine, you would start with a smear. You don't want to compromise, delays to start treatment. So start treatment and then, transport the specimen. And when the results come, for those few patients who are suspect for MDR, change the regimen. But what if now the results from an expert center turns out to be negative, and then the smear was already positive? So you can see in that algorithm, X-ray was not factored in. Line probe assay for second line testing for the short MDR was not factored in. We are revising that next year. So, for me, I still recommend point of care test if that is possible, and decentralization of these services.
So GLI just put out a very nice book with new model algorithms, a menu of options, which I think are a lot more in the right direction and progressive based on all the learnings. But what I'm hearing from you, are you happy with your cartridge utilization? In other words, are you using your machines to capacity right now?
I like our guidelines in terms of the replacement of
So it's
but
bold. It's
but
very bold.
we're still having a lot of problems with the equipment itself. So one of the reasons why we put them together was that at least problems with technical problems, but it's getting better. I think that still we need to be more, something that was said here, to work with the doctors and nurses, that they have to trust more the new tools that we introduce. This is something that we have to work better, because there is still a lot of clinical treatment. Even they ask for the test, but they don't wait. And sometimes even when it comes negative, they start treatment. So an X-ray is very, very available. It's available for almost every patient, even more than a smear microscopy, an expert. But still they treat patients on clinical basis. So I think that there's a work to be done in terms of the new tools that will come for people to really understand the value in the chain of the clinical decision.
So by and large, I think all of you will agree when I tell you that in most countries, the more gene experts they do, the more MDR they pick up. Is that not right? Every single country, same experience. So Diego, one of the reasons why NTPs have been very cautious about gene expert is that this fact that if they released expert on a massive scale, they're suddenly going to be dealing with lots more MDR than they ever envisioned or budgeted for. So this whole problem of knowing the true burden of MDR versus not having a big enough budget. So is that partly why they are saying, let's not even go looking for it, because if we find it, we will not be able to adequately treat it? Did that come up in your study as one of the reasons for countries being cautious?
Yeah, I think so. I think I think it's spot on. So if you look for it, you'll find it, and then if you don't have the resources necessary to treat it, then what happens then? I think the follow-up question or the follow-up issue for me is, so what? So then what? I think from the participants in the study, it was clear that, as I stated in the presentation, we do want to know what those numbers are, even if we can't treat. There's good reasons why we want to know these numbers, but it's still the problem that we can't treat these individuals. So I think from a global community, we have to think, okay, well, why is it that countries can't treat? And once we recognize that, then what is it that we can do about it? So I think the next step is actually thinking through some of the solutions. Why are there trust issues with these technologies? You know, what is the responsibility of countries, high-income countries towards low and middle-income countries? So issues around foreign aid come up. So I think there's a lot of questions that okay, so why and the so what?
So I remember in 2010 when GeneXpert was endorsed, there was a pushback from some sects of the TB community that rolling out this test is irresponsible because we're going to find up with a lot of MDR and we're not going to be able to treat them. In 2017, I virtually never hear that argument from anyone. We've come a long way. Nobody's even talking about it. South Africa doesn't care. It's rolled out. They found the money to treat with MDR, and they found money for bedaquiline. Brazil doesn't care. Mumbai doesn't care. Mumbai is so bullish about GeneXpert, they're hurtling towards universal DST. And when I speak to the Mumbai manager, she's saying, yeah, I want to know how much MDR I have, because now I can advocate for more money. Because when I ask, I get the money. So it's almost like you need to break that barrier and say, we have a big problem, we need to find the money, just like the way the HIV folks did. So I want to now ask Pumiza, from a patient perspective, how important do you think it is for a patient to know their DST status? No, not just TB, no TB, but actually know whether they have MDR, which drugs they are sensitive to know. Is it XDR, is it pre-XDR? Tell us a little bit about the importance of this. We know from an NTP perspective, because that's based on money, budget for MDR, the high cost of second line. How does it translate to a patient?
Like, I'd like for us now to be a bit realistic. There are GeneXpert machines, so we say, but can you go outside of this room, like go to India, for instance, or South Africa? For instance, you can be checked at the same time for MDR, and you will find that you have MDR. But how is that possible that one of us won't make it? Like, one of us will die. That's the reality of
Even
it
if
now.
you find you have MDR, one person will not make it out of two.
So I don't understand this machine. Can it detect like what medication will work or won't work? Can it do that now?
I mean, it's better than smears in the sense that it at least tells us whether you are MDR or not. But you're right, once we know it's rifampicin resistant, we'll need to do additional DST to be able to come up with a good regimen. That's exactly what WHO has recommended. So there is much more work to be done, but we see it as a triage within DST. A quick DST, at least minimum, would be a RIF. And I was just talking to Shelley and Sarah from TB Alliance that for the new regimen introduction in future, the shorter regimens, at the very least, everybody needs a RIF. So in other words, that is the minimum we're willing to live with in the future. We obviously want more, and that's where sequencing, whatever else we've been discussing in this conference, comes in at the next pass. But are you saying, I'm still trying to understand your point, that the outcomes of MDR are so bad, 1 in 2 MDR patients will die. So you're saying it's not important to know if they have MDR or not?
No, it is important. I'm saying this because even now, in 2017, I still get Facebook messages, people telling me that they were diagnosed with MDR, but now it's XDR-TB.
Ah, okay. So you're saying you want to know well beyond that MDR versus no MDR into the actual, is it pre-XDR, XDR, whatever. We hear you, and I think that's exactly what all NTPs are working on. But the first step would be to even get rifampicin for all confirmed TB patients. That's what the universal DST at its most essential means, that every confirmed patient with TB should at least get a RIF to triage them into one of these two broad buckets. And if it's RIF resistant, then the system should be doing way more drugs than just rifampicin.
So one last question then, how is it working if people are wrongly diagnosed with MDR, whereas they had XDR, and they take the wrong medication, get deaf, blind, etc.?
Okay, so we have been dealing with a massive misdiagnosis by relying on smears for decades and not testing most people for MDR. The next level of misdiagnosis is only working with GeneXpert alone and not doing the additional drugs required if you are RIF resistant. And I think the countries have to at least push everyone to at least get a RIF in the first place. And then if it's RIF resistant, do additional drugs. Should be absolutely part of the algorithm. Whether it's happening or not is a different story. You want to respond to that, Beatrice? So what do you do in Tanzania if somebody's RIF resistance on GeneXpert?
Oh, I wanted to ask. So when somebody is RIF resistant, we start.
Second line.
We start second line treatment. We have not yet started the short regimen. We'll start in middle of this year. So we start the usual 18 to 24 months regimen, and then a specimen is sent at the central reference lab for confirmation with the phenotypic method, LJ, and then confirmed later on after 4 or 5 months, because with culture how it is. So basically,
you don't have LPAs at that centralized level yet?
We do have LPAs, but then the usability of it depends if there are inconcordances with different levels of testing. But otherwise, the traditional is either midget, liquid to confirm, or for follow-up for these patients who are already diagnosed, or a phenotypic LJ testing once the patients have started already treatment, and then modify treatment accordingly once the results are available. And now we're decentralizing services.
But you're saying results are available after months, so the modification of the regimen will happen late.
It will happen late if it happens.
So it's still a struggle.
Yes.
If somebody is MDR, to know whether they have XDR or something worse, because of the time it takes for the whole thing, secondary testing, to be completed, correct?
Exactly, that's correct.
And that's exactly what's happening in cities like Mumbai. Mumbai has done a great job of GeneXpert, but the next level testing with positive RIF resistance into cultures and LPA is a huge bottleneck, because the number of culture DST facilities dramatically shrink, right? So it's like a pyramid, right? If you have 100 GeneXpert, then probably have only one culture DST facility. Then there's a huge log jam of samples, and by the time the regimen is modified. Bettina, how are you handling this problem?
Yes, so the GeneXpert is a triage for MDR, and if the RIF is positive, the patient changes the level. He goes to a specialist, and the specialist will decide if they will start a new regimen and wait for the result, or if they're going to wait for the result to change the regimen. If the resistance is not confirmed, they go back to the primary care. But even if they are resistant, they will treat close to their houses. Their medication will be sent to the primary care, and it's going to be a dual follow-up from the specialist and the primary care.
So it's clear that in every country, there is already some form of sample referral system, patient referral system. It's almost impossible to do everything at that level of healthcare that we care about. So that means centralization is already built into all health systems. The question is, how well is it working, right? So as things stand, without any huge investments on interventions, if I asked the three of you from the countries, what is the average time it will take for a sample to go from a level 1 facility to a level 3 facility, and the results come back, and then a patient is retrieved, and the regimen is modified or whatever? What is the real life turnaround times are we looking at, and how many people are we likely to lose while we're waiting for all of this centralized stuff to happen? I think that is an important question, and how much can we shorten it with some smart investments in sample transportation systems, drones, whatever you want to throw into the mix, right? There are people doing that. ICT, using mobile phones to track samples, because we know in the Indian private sector, the centralized testing model, the national chain labs, do a brilliant job. They'll come home to collect your sample. They will give you a code. Your phone will beep the minute your sample is gone. They will ship the samples overnight. The lab will do the assays at night. And the next morning, you will get a bleep on your phone saying, go to this website, put this code, download your report, right? They're able to do amazing things with better logistics, courier, ICT, mobile phones, the whole shebang, right? And still deliver at a reasonable cost to an Indian patient because of the volumes and the scales that these large-scale private network hub and spoke models are running. So there are people, and the HIV, Anita did an analysis. BD has put out a whole JID supplement on optimized sample transportation solutions in a few countries. And invariably, when you intervene, things get better. But I'm asking, currently, without any major investments, what would an average turnaround time? You just said It'll take 4 months for your culture to come back. Forget cultures. It's a horrible example. Let's just even take LPAs, right? LPA is a centralized test. LPA can be rapid if you are going to get enough samples to batch. And what would an average LPA turnaround time look like in your country?
I think around from 7 to 2 weeks. And that's the same with expert. If the machine is within a district, then within 2 to 3 days, you'll get back the results.
But if it's outside of the district,
then it's
2 weeks?
Yeah, 7 days.
7 to 14 days.
7 to 14
Bettina,
days.
what would your numbers look like?
It would be the same for in the cities where the machines are closer, is 2 days,
Right.
and maybe 7 days if for other areas.
For others. And in India, any idea, Dina? Somewhere in that range. Okay, so could we live with say, let's even say 1 to 2 week delay for a centralized testing that's reasonably well running? Now, what are the likely losses? In other words, what proportion of patients will you never find again if you ask them to come back after 1 to 2 weeks? Any idea what your losses might look like?
Yeah, well,
I'm not going to hold you to the numbers. Just give me a guesstimate off the top of your head.
we haven't done a patient inventory studies, but the program review told us, from the review of our documents, that about a good 15 to 30% of our patients get lost, and it's even more worse with the MDR patients.
With an MDR patient.
Yeah.
Any idea, Bettina, what your losses will look like?
Well, it's a guess. I don't have the exact number. I think it's less than that because of the way that the health system is designed with community health agents. They can go after the patients when they get the results. So I would put something about 10% maybe.
Okay. Any idea what the India data look like, Dina?
The same, because
Can you use the mic, Dina?
actually in cities, I think it's, for example, if you take a DMC, actually microscopic center, actually the samples are transported by the healthcare workers to the lab, if it's nearby.
Okay.
So there you find the losses are less. But if it's in a periphery, naturally it will be like, when it is transported.
And anything that goes all the way to the IRL or the National Reference Lab is probably looking at a much longer delay.
Yeah.
Correct?
Yes.
Even just within the district or outside is probably 1 to 2 weeks. Anything that goes to the National Reference Lab will probably be worse.
Yeah.
So I'm very sure we are all asking the question, what can we do to optimize the system? Because I cannot see how we're going to have everything decentralized. It almost looks impossible to pull off.
Yes, Madhu, but why should we say everything decentralized? For me, if it's a simple rapid molecular test with one DST, like just rifampicin as it is now, that can be simplified.
Yes,
you know
that can be done, but all the RIF positives will still need help outside, right?
Exactly,
you still
but
need to refer.
Yes, and now I'm talking from the program perspective. We have opened up the algorithm. Everyone, all the presumptive cases. That's a tall order, even for a good functioning health system. Leave alone a health system like my country, which still has a long way to go. That'll be a lot of specimen transportation around districts, around you know what I mean. So
I'm careful not to say this or that. I don't think we are in that world anymore. We need decentralized options. We need to optimize it. We absolutely need centralized options. We need to optimize it. Question is, how can we integrate all of that into a well-functioning health system? Even with smears, all of you know that there's fabulous data in meta-analysis that even with smears, which are already decentralized, 15% are lost to follow-up, pre-treatment losses to follow-up. So it's actually stunning that we are losing that many patients by telling them to come back 4 days later, a week later, or whatever. So for me, I want to ask you from your perspective, when we ask patients to come back for a test result, say a week later, 2 weeks later, what are the likely factors why they just sometimes don't show up at all, even though they may know they may have TB, or there's a strong feeling that they've been told that you must come back a week or 2 later, and what can we do to get patients back into care?
Well, firstly, you must respect them. Do not call them suspects. Do not treat them as if they are objects. So respect, firstly, and also stigma. The way the nurses will talk to you and the way the people will be looking at you when you're wearing the mask. So it all comes back to the drawing board, how to talk to a person. It's not an object, it's a person, not a suspect, it's a person. So it all starts there. And then communication, like in South Africa, we have community health care workers whereby patients don't have to go to the clinics. The community health care workers go to the people there. They might want them to cough out the sputum on the thingy,
Okay.
so that they don't have to go. For instance, if you are living far, like in the rural areas, they will come to you. Then if you are like sick or not able to walk and stuff, they will take you to the hospital.
So one of the things about South Africa is when we were there, I'll give you an option. One of the things in South Africa is the result goes to the facility, gene expert, but nobody is there to open it, but the patient does not get the result. So in other words, the health facility is responsible, not the patient anymore. Patient doesn't even know that gene expert has been read positive. Marco, you have a question?
Yeah, I was going to say maybe we could open this up to maybe
Yes.
a few questions. I know that other people have things, and there's I think Famiza made an excellent point in saying that, you know, if I go to a doctor, I want to know what the treatment would be, not, you know, well, this is a first step, and then you have to go here, and then you have to go here, and then it may be changed in 3 months' time. And meanwhile, you're not getting any better, and in actual fact, now you're transmitting it. So, you know, to the point that developers are here, that's what a patient wants. They want to know not all of this information. They want to know, what's the best treatment for me? How can I get better? How can you help me? And not in 3 months from now, right now. Right. So that's an important point to say, number one. Number two, I was talking, and I was reflecting on this, and Steve is right here as well, that this isn't just happening in high-burden countries that have, you know, in low and middle income countries. This is happening in high-burden country, or in high-income countries with low burdens, because the physicians and the system here doesn't even recognize that this is going to be even a remote possibility. And even though that we have the technology, the facilities, and the infrastructure, we still have the same problem here. So I'm wondering maybe in future that we can start getting even some of the high-income countries and seeing that we're actually seeing the same thing. So it's not just money that's going to be fixing this. It's the infrastructure and how we talk with each other, and how we listen to patients. So I think that's an important point to make. But I just also wanted to give this opportunity
Yes.
to others.
Let's take questions now. We have 10
Great.
minutes for the audience interaction.
Beatrice, when you were talking about Tanzania, you mentioned that microscopy, one goal would be to further scale up microscopy even within the primary care setting. But then we also talked about tools on the horizon like Omni and how great it would to further decentralize. So from a planning perspective, you know, you're preparing your global fund requests for the next 3 or 5 years. How do you think about balancing kind of the current need to further penetrate with the reality that hopefully, ideally, you would be displacing microscopy further and adopting some of these decentralized tools? So how do you think about new tools from a planning perspective, from the diagnostic, but also even from the drug perspective?
Okay, so I'd say pretty much now we are, in programs, we are pretty much converted when it comes to these rapid diagnostic tools, because we've seen what they can do. You know, for the gene experts, for instance, it hasn't done much in increasing the number of patients, but you know, we've seen that our bacteriologically confirmed cases are now increasing in proportions. So that means more people are treated adequately, as opposed to, you know, being treated from clinical symptoms. But we have more than tripled our number of MDR cases. You know, so we are pretty much converted when it comes to adopting these new tools. So the plan for us is now to scale up the current machine that we are aware of, the 4-module expert machine that cannot be scaled down to the lowest levels of dispensaries and healthcare center, to at least have a geographical coverage and not worry so much about where there's HIV more and where there is this and that. So at least to have the basic coverage of having at least every district have one machine. And then with microscopies, we are now also realizing that much as we would like, just like Madhu is saying, to scale down, whether it's Omni or any other simpler and cheaper molecular test, it might not happen overnight. So we are planning to replace the regular light microscopy with LED microscopy throughout, because we have, out of the 900 and something microscopy diagnostic centers, only about 200 of those are LED, you know. So we are now planning to replace the the regular light with LED, and then slowly, as we get more information on the simpler rapid test, also phase them in lower centers. So in our current GF plan, it's there to increase number of the current expert machine to at least cover all the districts, and then add more LED microscopes, and then later on add a few expert Omni and the like.
Yeah, I often think about systems, and not just the technology itself. So for Tanzania and for India and for Brazil, let's just pretend you've got like an Omni type device. The price tag for the cartridge is going to be still $10 plus additional labor costs and all the other associated costs to implement it. And you've got your ideal triage test, whatever that is, and it's implementable. So what does the ideal portfolio look like? Knowing that a large number of people who are coughing and have a fever don't have TB, and you've got choices on how you allocate attention to different levels. A triage at, to screen out, rule out TB, refer upwards, or relying on high performance molecular tests with additional, high specificity as well as sensitivity. What does the ideal look like? What should we be striving for? 3 countries.
Okay, so I think you're very right. It's not only about the machine, it's about improving the general healthcare system, but also incorporating the other components, the patients, the community aspect of it, and all other aspects. So for instance, for the ideal for us would be, and we are thinking about that in this writing of application for the new, for the new funding cycle, to have at least digital X-rays. It's still very expensive. Digital X-rays at the level of the district hospitals, and then have these patients. We cannot have the digital X-rays lower than that, unfortunately. Have these patients whom we are triaging come to those facilities. And unfortunately enough, for these, even in these district hospitals, you'd find mainly there are radiographers, but not radiologists. So the purpose of thinking about having digital X-rays at that level is that, to facilitate easy communication between those levels and higher regional referral levels, where there would be a radiologist to, quickly send out the results back to those facilities. It's not easy, easier said than done, but that is where we're looking at, in addition to, what I've already said, and of course, strengthening the community aspect system and specimen referral.
So you're saying you will be looking at digital X-rays, Omni for some facilities, continue to use your current expert at the district level.
Exactly, and also
and you will still have LED microscopes to pick up the slack.
And strengthening the specimen referral system, at least not in the bigger context of strengthening the health system per se, but for the TB specific, having the riders in health, the borders, etc. Having the courier services, having to transport.
What will your portfolio look like going in the future?
Well, first of all, we need a good health system. A strong one. For me, as you were asking me what would be the ideal for me would be a multi-diagnostic platform that would actually help me to separate the most common diseases and not going for one and then for what and then for the next one. And I think that every other solution these days should come with an app, sort of an app, something that already built in the test, something that will facilitate the communication of the result, the interpretation of the result that could be implemented right away. And ideally, open enough to be integrated to the other systems that are already in place. So this, for me, would be the ideal.
Wonderful. Dina, what's the India's new NSP look like for diagnostics?
Yeah, I think it's
Use the mic, please.
I think it should be a combination of all this. like wherever possible, we should have, wherever the infrastructure allows you, we should have the X-ray. And then at the periphery as like the microscopy, and also like Omni, the point of care test. And of course, like as a good health system, so that all the delays and we don't miss a lot of patients.
Good. Okay. Amina?
Yeah, Amina Jindani, St. George's University of London. Some years ago, we were recruiting newly diagnosed patients for a clinical trial in Kathmandu. And when we did the pre-treatment sensitivities, we found to our surprise, many were streptomycin resistant. This was surprising because streptomycin was not part of it. So when we looked into it, we found these patients, when they coughed, they went to a certain market where the stallholder gave them injections of streptomycin. Now, my point is, we need to be much more ambitious with our diagnostics here and not just restrict them to health centers. What would you think if the local magician or pharmacy or somebody had a kit that they were able to diagnose the patients before giving them streptomycin injections?
Can you take diagnosis all the way to your informal provider in your local?
Yeah, I think it's very relevant actually. Like I'll go back to say it's easier said than done because these are people like, let's take we have what we call the accredited drug dispensing outlets. In short, we call them ADOs in Tanzania. They are very widely spread. These are not formal, your formal pharmacies, but they are the, drug outlets that would sell cough syrup. And these are looking for money. They are there to do business. So we have tried through partners to sensitize them, and the output at the time of immediately after sensitization is usually very good. And then it wanes down afterwards because then there's that aspect of what am I getting into it. But that's very important. And you don't even need complicated tools. A simple orientation of these guys who work at these drug outlets and a simple screening tools with your classical questions, asking them to ask those questions to patients, and if they respond yes to any of them, give them your cough syrup, but then refer them to a health facility. It works quite well, although there's that level of engagement that has to keep going on, otherwise it usually wanes off because they are there to make money.
We are out of time, and I don't want to tread on the next session. Maybe just one very quick comment, each of you.
I'm totally aware of the time. I think probably the one thing that's more a comment rather than a question is that probably what I didn't hear, which I think would be helpful at some point for people to think about, is the synergies, especially in the sub-Saharan sector or in that arena, for synergies between HIV management and TB management, because they're treated in silos currently. There's lots of lost opportunity for TB because there are much more clinics that have HIV treatment facilities, diagnostic facilities, and I think everybody here knows that about 70% of people with TB have HIV. So it's a really big misdiagnostic
exactly what I think
opportunity.
Bettina mentioned. The same box will do viral load, same box will do HIV, and TB is way better for us. Agreed, completely agreed.
Yeah, I had a really similar comment and was glad to hear, that two of the panelists brought up the idea of integration and these multi-disease platforms, and I was just wondering if you could speak to how GeneXpert, which is recommended for early infant diagnosis of HIV, and viral load testing is on the horizon as well as other conditions, and then also the urine LAM assay, which only works in people with HIV with very low CD4 counts, how those might present some opportunities and also challenges in terms of having to align TB and HIV diagnosis.
So let's ask this question. Are your current TB GeneXpert machines, are they also running any other test? Why not?
If the equipment is running other tests, that's why.
Yeah, are you also running other cartridges on the same TB GeneXpert machine?
No, just TB.
Why not? You have a big HIV problem. Could you not run viral loads on them?
Of course, but we're
not yet.
Not yet.
Could you think about it to optimize your machine?
I think this is the best scenario. But more than that, I think that we should go for different diseases when we are
but like Erica said, even if we go from TB to TB HIV,
I
that
agree.
itself is a big jump
sure.
in terms of our ability. What about your machines at the district level? Are you running anything other than TB on the cartridges, on the machines?
No, not in a programmatic level. There's some element
So
of
you also
piloting
have
here
a
and
big
there,
HIV
but no.
epidemic. So what is the problem in early infant and viral loads to be run on those machines?
I don't know. I think it just came in, this information, you know, and now
And the HIV program is separate from your TB program?
yes, it's separate from our program, and you know, it's an issue of interest from the HIV folks. The Gene Expert rollout plan or policy that we have was developed by the TB program.
Understood.
You know, so
The classic
Yeah.
TB HIV integration
Yeah,
problem.
so-
Okay, we are out of time, but I really want to thank all of you for your fabulous input and contributions.
Thank you, madam.
Thank you.